these days of cashback operations. She may or may not join. In fact, there she is, just joining there. Hi, Mandy. I hope the operation went well. Are you on mute?
Right, I'm here, and I'm probably going to turn my camera off.
Okay, so apologies. We've had from Sade, who's on holiday, and Anna and Stuart in her place. Welcome to Julia at the top of the table. So Julia's joined us from NHS England, but in the private capacity she's on the Night Bedroom programme, so wanted to observe proceedings today, so welcome. If there are no other apologies, we move on to declarations of interest relating to agenda items. Any declarations? None? Okay, so on to the minutes of the last meeting, which was the inaugural meeting, so quite a quick one. Rather than go through page by page, are there any issues or amends that we need to make to the minutes? None, so happy for those to be approved. Matters arising from the minutes, an action log, we only have one item and that has been action, so we're agreeing. I don't propose we go into any detail on that. So we move straight into the Chair and Chief Exec update, which I'll hand over to Toby.
Yeah, thank you, Chair. Just three things I wanted to kind of say at the start of today's meeting. Really to kind of point and reference things that we're not covering on today's agenda, but significant things that are moving and have been in the last couple of weeks. Firstly, and we'll touch on this slightly, we get to the quality and delivery piece, but in terms of preparation for winter and the inevitable pressures that we anticipate as we go towards the autumn and winter period. Last week, nationally saw the publication by NHS England of the National Winter Plan, together with some very clear expectations around service capacity across different parts of our systems all across the country. And also these around funding allocations as well into systems to support some of that work, and therefore there's been an awful lot of work underway, which has been running for a number of months across our system, but which is coming together now and bringing together some of the work around capacity, some of the knowledge around funding options. We do have some items, particularly the final part of today's meeting, that some of this. So the first thing I just wanted to acknowledge was that the huge amount of work is underway at the moment in response and feeding into that national position last week around winter preparedness. The second piece I wanted to touch on, which again is something which is currently we were asked together as a board, a number of further national guidance documents that have been issued that relate to the wider work of integrated care systems, which are particularly relevant to us in the ICB board. Firstly, guidance has been issued in relation to updated guidance for health and wellbeing boards and their roles in relation to place and how they connect with systems, and that's an updated guidance that hasn't been updated for the best part of the decade prior to that. So I know something that's both of our local authority college partners will be picking up and working through with health and wellbeing boards, but I think it's helpful guidance and clarity. The second and third pieces in relation to this, the ICP, the Integrated Care Partnership Guidance that's been issued in relation to the long-term strategic plans that in initial form need to be put in place by December of this year. And then thirdly, aligned with that, and this of course is huge relevance to us as an Integrated Care Board, the expectations and guidance around the development of our 5-year plan. Just a reminder, we need to have in place formally by March next year, but certainly by the time we get into kind of Christmas, January period, we need to have done some really significant work in terms of the priorities, the areas of focus, the deliverables that collectively we're committing to work through. I'm currently working with Naomi and our facilitators, looking at how we use a really significant chunk of our development session in September to enable us to focus on some of the work there around strategic plan, the ICB, 5-year priorities and the areas we need to concentrate on. And then the third thing, Chair, I just wanted to reference up front in the opening remarks, again, very much kind of topical, the focus on the impact in terms of cost of living increases. Very constructive conversations yesterday with Chief Executive colleagues across the NHS and local government, really just exploring both the impact from a public and patient perspective, but equally from a workforce and from a staff perspective across the public sector. We've asked our people board to take forward some work looking at particularly the staff side of that in terms of work that different organisations have already started thinking through, and local authority colleagues yesterday were also updating us on work that their respective places either have to date or are currently considering and looking in relation to how we support our population and support our workforce in terms of the pressures that people are feeling across the country in terms of cost of living. I'm so happy to take any comments or questions on any of the above, but there were three areas that don't really feature specifically on today's agenda, but felt important to acknowledge at the start of today's meeting.
Any comments or questions? Going to just move on then, thank you. Questions from the public. We have had some questions through, but they weren't relevant to the agenda, so they've been passed on to the relevant executives to deal with. So there are no questions for the board to consider, therefore no responses. So we move on to item 7 and Eileen.
Thank you, Chair. So you will have in your pack the risk management framework, which is definitely a work in progress, but it's our attempt in the first instance to move stuff over from the CCG to the ICB operational framework. I say it's a work in progress rather. I think there will be something about how we align the ICB risks with the system risks, and there will be some read across. There's quite a lot of detail in here. It talks about realignment of new chief portfolios and which how those risks link to our governance structure. So I won't go through it all in detail, but I think it is our attempt to make sure that there are no surprises and that we recognise what we are reporting, and that we are managing and mitigating our risks as opposed to observing, which is quite easy to do if we're not careful, so that we're well sighted. So this is for assurance. It will undoubtedly come back in different formats and guises, but I think that this wraps around what we have moved over, and then we'll build upon that. But obviously there's a bit of chopping and changing to go because of course the portfolios are very different from what they used to look like. So there are some common themes which won't surprise anybody. So whichever risk register you look at, workforce definitely appears, as do quality and safety, not surprisingly and rightly so, systems and partnership and finance. So there are some commonalities, and it's really just making sure that we are reflecting what it is we are trying to manage, but also that it actually becomes live and meaningful as opposed to a document that we will either worry about or don't worry about, depending on what's on. So happy to take questions.
Okay, can I open up for questions? Afsal's been up on the screen first with his hand up, and then come. Afsal.
Yeah, thank you, Chair. Chair, as you'll recall, because you were on the Audit Committee this morning, we also discussed this item in quite some depth. And Eileen, I suggest that if you catch up with Sarah, she can give you some of the detail of that conversation. I thought some good and helpful suggestions, but overall, we thought it was a very helpful paper, a very good paper. And I think some of the key messages from the Audit Committee were around less is more, I think is a comment you made yourself, Chair. I think it's important to make sure that the risk management framework clearly is aligned to our strategic objectives, and therefore clarity between the objectives of the ICB as opposed to the ICS. I think that's important. And I think the other comment around the board assurance framework is just to make sure that it is a living, breathing document which helps the board conduct and carry out its business. So some really useful discussion at the Audit Committee this morning. Clearly, on behalf of the board, the Audit Committee's responsibility is to ensure that there's a framework in place and it's working, but also making sure that the kind of risk horizon, emerging risks are coming through quite clearly for the board to consider. At the same time, recognising that risk management is the domain of the board, but the Audit Committee and the other committees have some work to do to support the board. Thank you, Chair.
Thank you, Afsal. Krishi and Janet.
Thank you, Chair. I just wanted to make a general observation. I think the process and the sort of integration, if you like, of the risk tolerance and the registers, etc., is appropriate. But I do think it's really important that as a board we have a collective understanding of what our key risks are. And I'm sure we would all agree that, but what I wouldn't want this to be is all about the process for getting there, but actually having a sense of what it is we need to be worrying about, either in the short term, and what are we doing to manage that. So the sooner, and I do think it's important that we don't make, aim for perfection in these things in the first instance, that we have a good understanding of what we wish to have oversight of as a board, and we have some thoughts around how we manage that. And then absolutely it needs to be refined and reviewed and all of the other things, but I wouldn't want us to wait too long before we have a shared view of that captured as a board risk register.
And that was very much the conversation we had with the committee. How do we know the red flashing light quickly? Joe?
Yeah, thanks. So it follows on from your theme there. But I think it is about having a shared understanding of what's in the risk register, and to some extent an opportunity to understand what we're scrutinising. So I feel that it would be really helpful that if people could have an opportunity to come together and to go through it and perhaps be able to challenge any assumptions or question or advise on any areas, I'd certainly find that really helpful.
Yeah, and a good comments made. It's just in relation to, obviously, Simon and I have been working on the collaborative development, and there are obviously key areas of the transformation at different stages, and I'm sure it's part of the work, Eileen, but it's about how we're going to recognise how their risks interrelate to the ICB, particularly when they are working and will have their own risk registers, those sorts of things, which I'm sure you're thinking through, but just to put on selective development, please.
Thanks. So on a note of the thematic topic, Toby started the meeting by referencing the challenges that sit before us. It would seem to me that that's probably one of the key risks that we're going to face. Could I ask that consideration be given to that as a how do we respond to it? Because it's going to be one of our biggest early tests system in terms of how we come through what we all anticipate being a challenging series of months ahead. The other thing I think we've discussed as chief executives is the framework is obviously necessary and very important, but the operational mechanisms that we put behind the framework to manage risk on a day-to-day basis, particularly clinically, and particularly to do with mental health, are going to be really important. So I think we should ask that as this work comes back to us, we look at what are the operational ways in which we're going to manage risk across the system. One of the risks we face is that risk can aggregate unintentionally in different parts of the system. And so I think Matt and Yvonne's role, particularly holding the clinical ring around this and encouraging that clinical conversation about how do we manage risk is also really important as well.
I think you want to come back on those points.
No, only insofar as I made note of them, and I will just make sure it's reflected. And that it's real as opposed to just
Okay, any further comments? Okay, so moving on to item 8, and Sarah, the finance.
Thank you, Chair. So colleagues, I think Naomi has a
Sorry.
That's right. It's just a general comment. The sound quality is terrible. So I don't know if people aren't muted or if there's anything that can be done, but certainly Jonathan and I are both struggling. I don't know if Afsal is okay, but if anything can be done, it'd be really helpful. So that was all. Thank you.
I shall revert to Emma to see.
I will move these speakers then.
Okay, thank you. You carry on.
Or attempt to.
So in fact, we've got what is a month 3 finance report. So colleagues currently across the system working on putting down an analysis of month 4. So this is based on month 3. I suppose partly to explain the emphasis of the report, the ICB inherits oversight of the CCG close down process, and therefore this report is quite heavy on the CCG financial output for month 3. As we move forward in terms of the balance between ICB organisational reporting and system-wide control total reporting, that will change. But the main highlights of the report, therefore, CCG reported a break-even position at month 3. We had a £6.2 million underspend against the month 3 allocation, largely an issue of phasing. In line with national process, what that meant was that our allocation was top sliced by 6.22 million to achieve a break even, and that allocation has been bridged into the ICB allocation for months 4 to 12. So the resources retained and phasing is altered. Those underspends, just for note, largely in SDF, in terms of some of the private providers for elective, and in terms of some of the pass-through money for the East Midlands Cancer Alliance. But as I say, that resource has been retained and moved across into the new organisation. The detail of the finance report I will take as read. There's nothing in there that I particularly want to draw attention to. So just to move on to section 8, therefore, which is a summary of the system financial position. It's page 28 of the roll deck of the papers. The system reported a £3.3 million adverse variance against system control total as at month 3. Variances manifesting in the 2 acute provider organisations, which were almost entirely down to assumed clawback of funds around elective recovery. We have since received guidance, which means that we will account for that differently as at month 4. So don't expect that to be a continued driver for variance, at least in the second quarter. I think the thing is to say we are all closing down month 4 currently, but I think it is fair to say that month 4 is indicating, given it was the first step up in our efficiency programme after months 1 to 3, that we are starting to see financial pressure manifest in positions across the system, and that will therefore need some kind of careful management as we both look to understand that better over the coming week or 2 in terms of closing down those positions, but also monitoring it and resolving and mitigating it over the rest of the year. They're the points I wanted to draw out of the report. I'm happy to take any questions.
Any questions?
Just 2 comments really. Firstly, just a very practical point, building on your reference to the fact that there's lots of things in this paper that talk about CCG, which of course the statutory body doesn't exist at the moment. There are a few other things in relation to close down of CCGs that it's now been agreed with NHS nationally will need to be routed through this board, simply for the practical reason that this is now the only place that exists as a statutory body to do that. So for the market that don't think we've got the wrong agenda when something comes out in the future with a couple of those things on it. The second more substantive point is to your reference to where we are, or think we're likely to be at month 4 at the moment and moving forwards. I think it's to note that the kind of pressures that we see from an NHS perspective, I know from conversations we've been having at early stages with local authority partners, there's I think something broader here about how we understand some of the financial challenges and pressures that we're facing across health and care in terms of local government and the NHS, and in particular the interplay between some of those things, particularly in terms of decisions and choices that partner organisations may quite legitimately feel they need to take over the next period, but understanding upfront rather than after the event the implications of some of those things. So that's something, Chair, that I think we'll come back to further rather than here today, but I just wanted to log it as something which I think is of significance for us as a system. We're not unusual in that, that we always knew we had a plan this year. From an NHS perspective, we have significant risk in the plan, and the further through the year, the more those things either start to crystallise or to unwind, and that'll become more evident as we go forwards. Thank you.
Thank you. Angela.
Yeah, just in relation to what Toby mentioned earlier, the sort of winter planning, and clearly people are feeling that pressure. So a sense there in terms of that winter money or support that may be coming through, and how and in what way are we as a board going to keep that clear sort of safety quality lens going forward, notwithstanding the financial pressures, because Toby's mentioned, but I'm sure in all of the areas we can all signal those pressures, they're everywhere. But again, just to talk from a mental health perspective, which is important, I do, occupancy is 100% across all of our bed positions, and that is not an easy position to manage. So it's how we're going to manage that safety quality perspective with the pressures you're describing tonight.
Any other questions? I think from an integrated planning perspective, our sort of summary was there is significant risk to the budget, and we'd rather make a call quickly in terms of where we're going to end up and what mitigating actions are necessary, rather than wait until October, November, when actually there's a lot of time in the financial year. We're going to be by winter. So I think there's a word of caution basically in terms of budgets, and we'll be sort of expecting an update really by September when we'll have more view on that.
could just come back to probably Angela's question and also talk about some of the forecasting work. So as a group of directors of finance, we are working on a significant reforecast of the system position by the end of Q2 in terms of working some of that through. I think in terms of winter, there is a national and a regional process running around G&A bed capacity. We have made a submission to that, as have all other systems, and we're currently still waiting notification from regional colleagues in terms of the allocation, the potential allocation of the system. What we will then need to do as part of the winter planning that we described at the beginning is to work through the financial allocation and prioritisation of the schemes around winter. And we will do that obviously with clinical and operational colleagues around this table to ensure we put that money to best effect and mitigate the risks that we've got. But currently we're still waiting for formal notification from Abby.
Yeah, just to say exactly what I think that's where we come back to our earlier conversation about risk and clinical risk. I think that's where it's really important that the clinical risk plays into what we prioritise and how we get best value for money in the safest possible way as well.
Simon. There's a common theme to some of the comments that have been made around demand and capacity, and I think between health and care, I think probably building on your comment, Toby, I think one of the key tasks that still sits in front of us is to agree system-wide a demand and capacity plan. So it applies as much as mental health as it does to the acutes. Yeah. And I think we don't yet have an integrated understanding of, are we in surplus or deficit? I mean, I think we've got an operational understanding of some of those pressures. But really and truly, we need to be looking forward into next year and looking at some of the likely shapes of capacity that we will need compared to the demand that we expect to have. Because you said that was a key priority of our work as we came into existence. And I think the last few months have demonstrated even more that is a key priority. So I would very much welcome putting that onto our work plan, because I think all of us around this table need to own those numbers and understand them.
Jonathan.
Yes, just mainly to support things that have already been said, but also to extend the conversation into just an acknowledgement that general practice will keep going and keep going and keep going, but then when it gets to a certain demand capacity envelope, some practices will get into quite significant trouble and may fall over, and that will particularly happen if there's any sickness anywhere in the general practice system, because a lot of practices are absolutely running on the rock bottom of recruitment and have been for 2 or 3 years. But if there's a significant spike in demand during the winter, which would not be perhaps unreasonable to expect, we just need to be alert to that, I think. Thank you.
Thank you. Any further comments or questions? Okay, thank you, Sarah. So we move on to item 9, the ICP outcomes framework. Massimo Roisin, over to you.
Thank you, Chair. Please take a moment to introduce this, and if I may make a comment that applies to this and the subsequent item on the agenda, in that were we to rely on internal reference, we might sequence the order in which we produce things in a way that might make more sense, perhaps. But it is as it is, and would just like to acknowledge up front that there is work to do to then start to align the different pieces of work such that, for instance, our strategies and plans aligned to our long-term outcomes framework, and work is ongoing to that effect. And we recognise, therefore, that this is an iterative process, and on a small technical point, but nevertheless a significant one, would like to offer a clarification in relation to the item that Roisin is about to present, in that the outcomes that have been agreed arose out of a workshop at which representatives of the ICP were present, rather than the ICP per se, given its current state of constitution. But with no further ado, I'm very grateful to Roisin, who's done a huge amount of work, for joining us to present the outcomes framework. Thank you.
Apologies for that IT issue, but I'm hoping I can share the slides that are in your pack to talk through. Make sure that everyone can see that on their screens. So So as Matt's already alluded to, the sequencing of things, I guess we're bound by national timescales and timelines, and possibly not the most helpful timescales. But the ask here was to develop an ICP ICS strategy by December 2022 in order to influence that first 5-year joint forward plan of the ICB. And really integral to that system-wide strategy is all actors in that partnership agreeing on priority outcomes and an outcomes framework in order to drive forward that strategy and actually to be able to know that the partnership is affecting meaningful change. As Matt said, a number of ambitions were agreed by a group that comprises some of the representatives of the current integrated care partnership, I understand. Those were the 10 Live Your Best Life ambitions that were agreed. So that has been the framework, I guess, that we've started with in order to prioritise those ambitions for the partnership. We've also used existing needs assessments and the existing NHCP outcomes framework. There are certain priorities that have been identified for a number of years in a row that's still relevant here. We've not started afresh. We've absolutely used those and built on them. And when there are new priorities or new issues that have been identified by stakeholders, included those in the outcomes framework. Through July and August, we've been undertaking a lot of engagement work to understand from stakeholders. So this is what we believe from our desktop research and existing needs assessments might be priorities in these areas, but asking stakeholders what do they know about more recent data or more recent pressures and priorities that we should be focusing on in the outcomes framework, and bringing this version of the outcomes framework to the ICB at this point is part of that engagement process. So I really want to emphasise that at this point it's very much a draft and a working document for your feedback rather than endorsement of a final product. So moving on to the actual detail of the framework. These are the 10 Live Your Best Life ambitions that I mentioned that the strategy and outcomes framework is shaped around. And what's really important about this set of ambitions is that they really thoroughly cover the wider determinants of health, the social determinants of health. And we have had feedback from colleagues that have worked in other systems and with other ICSs that actually this seems to be not unique, but we seem to be one of the few systems that are working on outcomes framework that really pushes the wide determinants, and so real early upstream prevention in a way that other systems, I guess, maybe more pragmatically, are focusing just on health and social care outcomes. So just to note, the board, I guess, informal feedback has been that this is really pushing the envelope, this approach. To touch really briefly on some principles that we've used in shaping the outcomes framework that I've already mentioned. So we're very much building on what we know from our existing needs assessments, our priorities, but being really flexible in our stakeholder engagement to bring in new priorities that are popping up. As was mentioned earlier, new guidance is being published frequently on different parts of ICS development. We know that there's going to be statutory guidance on the shaping of ICP outcomes frameworks next April 2023, which indicates that this is very much going to be an iterative process. So as well in the statutory guidance around strategy development, there's a section that talks about how outcomes and priorities should be reviewed annually as the JSNAs are published annually. Touching on some other principles, we really want to get a balance between having an outcomes framework that was strategic enough and high level outcomes, high enough level outcomes so that it's useful for the board to see a really broad view of the system, but without losing the detail underneath that. So a balance between it not being too cumbersome and losing detail. And then finally, we'll come on to the health and inequalities plan, I know that later in the agenda, but reducing inequalities should absolutely be a golden thread throughout the outcomes framework. The structure that we've taken is that each of those 10 ambitions, for each of the 10 ambitions, we've articulated a number of outcomes, which is what practically we need to achieve in order to deliver that ambition. And then for each outcome articulated how we're going to measure what are the metrics we're going to use to know whether we've achieved that outcome. A theme that has come up throughout our engagement process is that it's really difficult with a single metric or even 3 or 4 metrics to really tell the story about what are really complex, nuanced outcomes. So we're very much understanding that this is going to be the best that we can do in terms of trying to illustrate where we are as a system. We're never going to get the perfect measures across all of these outcomes, but it is a work in progress, and B, a sort of a starting point for more nuanced discussion around each of these outcomes. Our stakeholder engagement to date, so all of the groups that are on this list have been engaged with. I haven't actually got final feedback from all of these groups. I'm due to speak again to a number of them. I'm constantly getting email feedback from a number of these stakeholders, but we've engaged a wide variety of stakeholders. And I've touched on this earlier, timescale, so I won't dwell too much on this slide because I know we've got limited time. Some of the discussion points that we've been taking to our stakeholders, we've asked for feedback on the language and the wording of the outcomes themselves, as well as the detail of the metrics, as well as looking at to the future of when this becomes a working outcomes framework, how the governance might work and which boards or groups might own particular outcomes or ambitions to feed back to the ICT board. So we now come into the detail of the outcomes and the metrics, and as I said, it's a work in progress. So actually the version, I think it's version 5.1 possibly, that was circulated in the meeting papers. There's been a lot of work since those meeting papers were published, so some changes to the metrics here. So I think I should pause there for any comments on those existing metrics that were circulated, and I can, now that I'm logged onto the screen as well, I can then share, if someone wants a more detailed discussion, the latest version or thoughts. So yeah, I'll pause.
Question, thank you.
Thank you. So we look at for questions, comments.
So I know you came to us an energy expertise, so again we're feeding comments through. It's really helpful, and it's really good to have that engagement that you're doing, which it really is. It's just in terms of things that the ambition, absolutely, in terms of what's coming across, our access to health and social care services when they need it. I suppose it's the risk. How do we manage the risk of access across all sectors, all populations against the greatest need? It's just a question. It may not be possible to answer at the moment. It's just a thought that I've got in terms of, are we focused on particular populations? Are we focused on particular risks, particular health inequalities? How will we manage that access ambition, for example?
So I might come to Matt for the managing risks, but in terms of the health inequalities piece on that, so we have done a separate cut of these indicators to map them across to our health inequalities plan, and found that I think 90% of the metrics in the health inequality plan are part of the high level outcomes framework. There are a couple that aren't, but for each ambition, we very much see that there will be envisaged that there will be detailed scorecards underneath the say eight high level metrics in a particular ambition area. They will give a part of the picture, but underneath that there will be a detailed scorecard that has a narrative describing what the hard figures don't, as well as a section on key inequalities for that particular ambition, which will address the other metrics in the inequalities plan that aren't picked up in high level outcomes. So yeah, absolutely, in that more detailed scorecard, I think what is where the decline inequalities will be picked up.
Thank you, Roshan. And if I could just add to that, Andrew, I think you're absolutely on point as usual. I think as Roshan says, behind the high level metrics, there's an awful lot of detail, because we are going to learn to an extent on the move and iteratively how to refine this. And what your point touches on as well, which is the thing that sort of occupies my mind, and that we're starting a piece of work on, is, of course, if we want to improve outcomes in the long term, we need to have metrics that are more near term, but have to feel really confident that they are good surrogates for long term outcomes. And I don't think we're fully there yet, hence the iterative nature of this piece of work. But that is very much on our minds, I think. And some of the metrics that are in the current state of maturity of this document may well drop out if, as I suspect some of them will, turn out not to be particularly good markers of long-term outcomes. If I could pick an obvious example of that, the emergency department 4-hour standard isn't necessarily going to be mapped well to long-term outcomes. So I think your point's well made. Is a short answer.
We've got Naomi first, then Christy, then Toby, then myself. So Naomi first.
Okay, thanks very much. And I mean, I realize this is a massive piece of work, and I'll be quick, because one of the problems is, as a board, we don't have time to discuss these in detail, and there's massive amount of detail here. So the first thing I want to say is, congratulations, the work is going really well. But the initial comments you made about the breadth in terms of the 10 ambitions is great, except that what I want as chair of the board is those things that we will be held to account for as a board by the population of Northamptonshire and by NHS England. And I don't want to be held account for things that I can't do. So there are things in there that, as we progress this work, as you say, we have to really filter out in terms of, so who is going to be held to account for that ambition? And they won't all be this board. And indeed, they probably won't all be the Integrated Care Partnership either. So I think that understanding is really important. Secondly, it's a very simple point, but one I make a lot. That example of access is not an outcome. If the person doesn't get the service, it's unlikely the service is going to work. But just because the person gets the service, it doesn't mean it achieves the outcome. And so for me, in terms of what the Integrated Care Board is responsible for, I don't want access. I want this. This is where we are with this group, and this is the problem, and this is where we want to get to, and we can measure those two things, where we are and where we get to. I really want to start with the data, and the data determine what these 10 things that this board is held to account for. Thank you.
Okay, I'm going to take 2 or 3 comments at once, because there's lots of people trying to get in. So, Christy.
Thank you, Chair. Really, a very simple point from me. It was just about priorities, and I suppose I think it links to what Naomi was just saying. There's an awful lot, and I can see that a lot of thought has gone into it, and it's helpful to have the framework. I just think we need to be really clear what we can actually make a difference on, and I suppose because the discussion points said, if you could have only one metric, you know, per outcome, what would it be? I don't want to say that because I don't think I'm the right person, but I do want to say that I think it's important is what do we need to do rather than what do we want to do? And what is going to tell us what we need to do? You know, what's the analysis that's going to tell us these are the things that we really need to invest in that could make a significant difference to our population? That I would like to see more of that built into this, if that's possible. Linked perhaps to the inequalities. Thank you.
Toby. Thank you. As others have said, I think this has progressed really, really well. It's a huge amount of work here to build on some of the things that Lucy and the team started a way back, and it's good to see it kind of moving into the shape that it's in. I really welcome the broader approach here. I think that wider determinants piece is really key. And when I see people interviewed to the wider partnership, I think it's critical that those things are captured in terms of education, employment and housing. Echoing though both Naomi's comment and also Christian's comment, I'm really glad to see in the discussion points the suggestion around actually identifying, I suppose, lead body, lead organisation, lead agency, because for me these things don't mean anything unless we can hone them somewhere. And I'd be really interested to see, and I'd ask, I don't know whether this is doable, but for our 7th of September session, sorry, 15th of September, when we're together as a next in our informal session, we're going to get into more of a focus there about our 5-year plan and early work. And I'd love to see a cut of this that kind of starts off a discussion about out of this 70 or so, what's the, I'm making this up, 25, 30 that we think are primarily in the wheelhouse of us as an integrated care board. And of those, if you look at the data and our benchmark position and inequalities in place, which things float out of that has been the things that really we ought to be putting differential input into and building into the plan side of things. So it's kind of how does this move on to that next stage? And I'd welcome a view on how doable that is, but my guess is quite a lot of data does already exist behind this. And so I'm keen for us to start using it to inform that early thinking around strategic planning, noting that it will be iterative, it won't be perfect, it will look a bit different next year. But at some point, I think it's really important we use this as the compass thing that sets the direction we need to head on. And if we could get some of that cut of this, which would start to turn it into something more specific and prioritised, I guess, for us as an ICB, that would be really welcome. Thank you.
So I'm going to pause there, see if there's any response to that set of questions.
Sorry, just an overarching response. First of all, the feedback is fair and helpful, and I think that the suggestion that we seek to sift and distill this down to circa 20 to 30 metrics ahead of that, the workshop in a month's time is really helpful. It helps you, and I'm just looking to my left to make sure that before I accept that Roshan agrees, that will be his blood. So.
Yeah, absolutely. And actually, Matt and I have spoken about that before, and we do have a cut that's ICB focused, not the wider partnership focus, that we'll work on, but that's absolutely doable.
Okay, so we've got 4 more people, so we start with Atal.
Yeah, I put my hand down because I think the point that I wanted to make was around priorities, which is a lot well made by Naomi and Toby just now, and just recognising that we've got a finite amount of time and finite amount of resource. So I think the priorities point is well made. And whilst I'm sort of on, the other point I wanted to make was in terms of the metrics here and the outcomes, just some kind of plotting of when we think these might be delivered, what is our target date, not only what we're trying to do in terms of outcomes and how we're going to measure them, because clearly we're not going to deliver them all linearly in year 1 or year 2. So a recognition of, when are we going to hope to deliver some of this stuff. But my key point was around priorities, and that's well made. And I think that's a really important one, including the one around accountability. Thank you, Chair.
Thank you. Rob.
So yeah, I don't want to repeat quite what Naomi and Toby and Commissioner said, but I think there's a question you've raised in there around what other existing strategies and outcome frameworks. So Stuart and I will have corporate plans or whatever we call them for the local authorities, and they will have a number of these which are statutory responsibilities. Take homelessness as an example. So you may well be interested in it, and that's fine. If you can help us, brilliant. But the statutory responsibility will sit with the local authorities. Could understand why that's in the partnership. So for our focus as a board, would we have a conversation here that would do anything to help with homelessness? I don't mean this badly, I doubt it, but what the what. So the distilling down into what this board can really help influence, I think is really, really important. There's a few of them, and I'm sure there's other ones in other parts. So I think that's how, don't Stuart, I don't want to speak for you, but that's the way I looked at it, that we need to make sure, again, let's go back to my members, councillors who will say, what's all that doing over there when it's our responsibility, which I need to make sure they don't see it as.
Stuart, do you want to come as well?
So I suppose just reflecting on people's comments and the kind of notion of wider determinants around this. The other expectation of using this theory is about how do we maximise partner contributions in its broadest sense to what are the wider determinants. So to follow on from kind of Rob's point, if you look at that ambition around people feeling safe in their own homes and when out and about, our local community safety partnerships have been engaged in and around this. Our local police forces, as a result of this, are looking to orientate the policing beats around what will be the geographies of our local area partnerships which have delivered at place, which means as we start to get into integrated teams in their broadest sense, we are starting to bring together partners from a much broader sense orientated around the same geography. When we start to get into housing, so from a West Northampton perspective, our housing strategy will be structured around our 9 local area partnerships. There will be a housing partnership board which will have ownership of that particular ambition. So I suppose as we work through this, it's about from an ICB board being really clear which of those ambitions pertain to and are the responsibility of the ICB, and where does ownership and responsibility lie in relation to the others. Equally, to take Rob's point a little further in relation to homelessness provision, whilst the ICB doesn't necessarily have a role in the context of providing housing accommodation, we know that we have entrenched homeless individuals with significant drug and alcohol issues who are prevalent attendees in our GP practices, in through our A&E and into our specialist services. So that ability for the ICB to say, what are you doing, local authorities, in the context of dealing with homelessness, allows the ICB to get a grip of and put forward more collaborative interventions that reduce the impact on health services of those people with higher needs. So it is about how do we get into the ownership of this in order to break it down into chunks of responsibility that individual features of our local system can drive forward.
Thank you. Jonathan.
Thank you. 2 quick points. The first of which is, if you're a fidgeter, it's really good for your weight and therefore your health. But while microphones are on the floor, it sounds like there's a troupe of Irish dancing girls in the room with you. Forgive me that slightly humorous intervention. But my serious point is concerning access and particularly metrics. And I commend a careful reanalysis of any metric that involves a survey, because a survey speaks to patients' wants, and the National Health Service at the moment is only funded just about to need. So it's a pointless metric surveying access by telephone for patients, because patients would like to see their GP 24 hours a day, 7 days a week, whenever they want, with only a 5-minute wait. So that metric is pretty poor, really, and I think should be binned. There are many other ways of measuring, for example, access to general practice as an example, but in general, I think we need to be careful. So patient surveys, I think, are wonderful for identifying what the population would dearly like, and that might influence strategy. But going into the weeds with what's funded has got to be identified only need. Thank you very much.
Thank you, Jonathan. And then Simon.
And thanks, welcome the work, and thanks for coming along to the session with the execs recently. My comment was going to be, how do we develop a framework by which we can use this? Because developing it is one thing, but in actual fact, this should be implemented in every discussion, every meeting in different ways, no doubt. But in particular, it should obviously support our investment decisions as we go forward. And I think we need to give that some thought before we get or in parallel as we develop it. Otherwise, we will end up encountering how do we use it at the first time when we have to make some decisions. So I'd welcome your thoughts on that, not necessarily now, but I think it's a really important part that we make it the day-to-day of what we do. My related point was going to be on synergies. I think there's a lot of opportunity for synergies, Rob, to your point. So we know, for example, homeless people are the ones who are least likely to have access to primary care, maybe get less physical checks when they're in hospital, or their discharge experience in hospital is challenged because of their status in terms of their housing. So I think we should take every opportunity to look at how we can support each other as we develop these plans through synergies.
Any comments?
Can I come back on that?
Please do.
On the particularly primary care access, that is feedback we've had from primary care clinical leads as well, and so we're absolutely looking at a different metric specifically on that point. The point around focus of where the ICB's accountability to wider the wider determinants. I guess one of the principles that we used when building the outcome framework was this is an integrated care system, integrated care partnership outcomes framework. What are the outcomes that that we can best shift by working together as a whole system, as a partnership, rather than outcomes that actually one agency could meaningfully affect change on its own. So while we can absolutely identify metrics that the main accountability sits in one agency, I guess the beauty of the framework is that a lot of the outcomes are outcomes that need the whole system working together on.
Thank you. And just to Simon's point, again, well made, with the analogies that I would draw, it's not too tenuous, is that really highlighting the importance of getting meaningful outcomes and appropriate surrogates to track progress, because that is the basis upon which we're going to build a strategy, and then effectively the assurance framework, not dissimilar to a path that should direct all of our strategic thinking and investment decisions. It's a bit of an oversimplification, but that's broadly the approach.
Good, thank you. Stuart.
Just a final point, just following on from Simon's comment about how we start to use this. So our current thinking is that actually when we get into our local area partnerships, we will do local area profiles based on the data that's available in each of those local area profiles. We will do that against those 10 live your best life domains, which will then allow us in each of the local area partnerships to have an understanding as to which of the ambitions we're doing better at, or which of the ambitions require a more consolidated or different approach to move things forward. Because I think what that starts to do is recognise that across both West Northants and North Northants, our local area partnerships are uniquely different. This allows us to start to get into conversations about how we might want to operate differently in each of those areas. Ultimately, we need to think about then, well, what does that look like from a system perspective in informing both our prioritisation and our investment decisions.
Excellent. Thank you. So, general support and direction in the right way. I think that there's a clear message of distilling the ownership piece, and I think permission from the board to sort of start mapping that out. Not for sort of the detailed work in terms of what happens next, but actually a clear view of who's responsible for what and where there are areas of collaboration, I think is critical. But thank you very much.
Thank you, Chair. Thank you, Richard.
So we move on to the next item, closely linked, which is the Health and Equalities Plan. Still with you, Matt.
Thank you, Chair. And as a brief update to the second presenter, who is also Roshan and not Chloe Gray, as we advertised. Apologies for that. So, remembering the earlier comment in relation to sequencing of events, nevertheless, delighted to present the Health and Equalities Plan, recognising that it was submitted rather as the cart before the horse. And there is work now to do to map it back across to the emerging outcomes and make sure that it is seamlessly meshed with our 5-year plan in due course. I have some further points that I make in relation to how we should do that and take a steer from the board. But before I do that, it might be helpful to ask Gretchen to walk us through the storage study. Thank you.
Thanks, Matt. I'm here for Sally, Director of Public Health, and Chloe Gay, who developed this plan, and I understand that a shadow version of this board has already been involved in the development of the Health Inequalities Plan and seen this already. So I won't go through it in too much detail, but just to say that in developing this plan, the aim of the team was very much to develop a set of broad guiding principles of how we should address health inequalities across the system, rather than with some more specific actions around delivery, but rather than getting into the detail of delivery, trying to set out some guiding principles and enablers, system enablers, to ensure that health inequalities are addressed systematically across the ICB. And those principles you'll find in part of the plan are around working together and everyone's responsibility being seen as reducing inequalities. And that's about providing services that are accessible and culturally appropriate, but also recognising agencies and organisations as anchor institutions. So as well as service delivery being inclusive, thinking about the way as an employer or as buildings that we can influence and reduce health inequalities. As well, an important principle was being health literate organisations. So as far as we can try and have services that are accessible and culturally appropriate, ensuring that we are a health literate organisation and really aware of health literacy of our staff as well as patients is really crucial. And then finally, community-centred approaches are seen as really key to understand the drivers of health inequalities that are more local. So local area partnerships will be really important in understanding local drivers as well as what we know about national drivers of inequalities. Those are some guiding principles, but we'll need some enablers. So having thorough and good access to training on inequalities, reducing health inequalities is really vital, but also having the resources allocated to specific projects and programmes to try and affect a cultural shift, because although a lot of the time this is about changing our approaches, changing our culture, sometimes we do need specific plans, projects and some resource to affect that changing culture. And then finally, all of that should be based around data and having better access to data. I think one of, and you'll see when the board sees the updated JSNA that's going to Health and Wellbeing Board in September, there is a real lack of data, both hard figures, quantitative and qualitative data around particular groups, communities that are affected by health inequalities. So that absolutely needs to be addressed if we want to know where we need change and measure that change.
Okay, thank you. So we're looking to approve the plan. So with that in mind, any comments, questions? Christian?
Apologise that I seem to be contributing rather a lot, but I'll make a brief comment if I may. So great to see it, and we did see it in a shadow form or in a development session previously, so I do recall that. I was just really reflecting that I know there are some key actions and that's helpful. It's just the action plan in the appendix is very long and there's a lot of actions. and a lot of them are dated 22, 23, and I'm just wondering how realistic that is, and, you know, do we need to refine that to really be focused? Because I just think with all of these things, we need to be really clear what we can deliver, what's realistic, and what's going to have the most impact. So it's helpful that there are the 6 key actions, but I do think it's important to refine this other action plan so that we're not stretching ourselves too thinly and perhaps not, you know, delivering what we really want to do.
Thank you, Krishna. And Chair, if I may respond to that, 100% agree. And indeed, I've already spoken to colleagues within the ICB and also the 2 directors of public health to that effect. And I think now that we are beginning to shape up our outcomes framework, I think, you know, there is a reasonably, I know there's a reasonably generous slug of funding for the priority area, and we are minded to refine this substantially, particularly around first-year deliverables, and to target that investment, acknowledging Roshan's point around whilst our data and intelligence function support our decision making has some progress to go yet. In the interim, that we know full well where our areas of greatest deprivation are, for instance, and it would be great to get on and do some meaningful things in those areas in year 1 with a significantly narrower focus than is set out in here, so we can actually demonstrate that we can do something that makes a difference and use that to then build and roll out wider. So your point is entirely well made, and thank you for furthering our thinking.
Thank you. Janet.
Yeah, I sort of, some of the points that I wanted to make have been mentioned and asked, but to me there's something about when you've refined it, whether or not you could produce a sort of webinar type thing, if that's the right word, where it could actively be, you know, sold to people, and people can understand what it is they're likely to get and what the impact's going to be. I suppose for me it's the so what factor, you know, because if we're talking about it, we're doing it, but actually what's the impact for a member of the public from their perspective? And I think there's so many web opportunities to tell that message. It might be a really good way of being able to do it. Just a thought.
It's a great thought. Thank you.
Thank you.
Thank you. Tony.
Yeah, thank you. I think the ask in terms of approving it is kind of the only right, sensible thing to be asking the board to do today, but I'd be a little bit less polite perhaps than Matt was about the sequencing of timings on all of this. I mean, to be honest, the only reason that we and you guys have put the effort and energy into producing this and timing you have is because it was one of the NHS requirements that the national process to have in place for a certain point in time. If all of the things we need to do, to be honest, we'd have done the outcomes framework bit, we'd have done the ICP strategy, we'd have done the 5-pack, and then we'd have kind of done this and run it alongside it. That said, I think this does provide, because there's some really good considered work in here, I think it does provide a really good framework to take into those other pieces of work. My only practical suggestion, Chair, would be the paperwork notes review date of July 23. I would suggest we might want to bring that forward to, let's say, April, at which point we would have an ICP strategy, a 5-year ICB plan, and an operational plan for 23-24. And that would, I would suggest, enable us to have a much more practical, realistic and detailed work plan that sits alongside it. So that would be my suggestion, that we maybe just look to move that forward. But I wouldn't suggest there's an awful lot larger energy in continuing to iterate this over the next few months. And therefore we ought to just kind of note it as where it is at the moment and then feed that work into those other things over the next 6 months. Thank you.
Tony.
Thanks very much. A sort of slightly different take, but agree with everything that's said so far. Of course, we accept I accept the paper, and I think Toby's right. There's no point in iterating it. So these comments are for the future. And what I find interesting is the more you tell me, the less I know. And basically, I don't know anything about the data on health inequalities for Northamptonshire till I wade through about 23 pages. So I'd want the summary at the beginning, the executive summary, to tell me for Northamptonshire, if we got X number of people to stop smoking, we would increase life expectancy by X. You know, what are the 5 things that really are the health inequalities for Northamptonshire? So I'm really pleased that our actions are about finalizing the governance arrangements. Well, that's an essential, but not a sufficient. So I really would like much more summary, clear data at the beginning in print that I can read. So once we have the data, then we say, yes, this is the most important thing to do. It takes a long time to find the actual data in the paper, and a lot of the charts I can't read.
Thank you, Naomi. I completely agree it is not sufficient, but also that actually getting the governance right is essential. At the moment, the Population Health Management Board, which has responsibility for health inequalities, among other things, could certainly be better plugged into the ICB committee structure to give it the airtime and support that it needs, and that is underway. Janet.
Yeah, so, you know, there's a huge amount of work gone into this. As you just said, you know, it's about getting it done and getting on with it. I think the communication of it is a really significant thing. But equally, when we're looking at prioritising, making sure the data's there and available, I think that's significant. It may well be that the underpinning work that we've seen today and in the previous board meeting is something that needs to be gone through. And as Naomi said about being able to be succinct with the content, my point about being able to articulate it in a visual way is also to recognise that other people might welcome it in different formats. Take your point about not going through iteration and iteration. I think where I was coming from was about simplification so that everybody gets it. Okay, thank you.
Thank you. Any further comments? I think with the caveats around refined action plan, a continuous improvement approach in terms of data, and then consideration of an inclusive approach to communication so that we actually involve everybody in it. We're approving that. I'm happy with that. Good. Thank you very much. So, do we have David around? I think 5 minutes early. You just outside of it. Waiting for David. Everyone's worried about moving there because Jonathan's had a go.
I think I've realised, Jonathan, while we're waiting, it's reverberations in part from people walking through the corridor outside because of where we place the speakers, so we'll get them elevated this time around.
Can we put them on the chair?
In the break, we could probably put it on the
Yeah, we'll have a bit of a rejig during the break, Jonathan, and see if we can cut out some of that background feedback that's bouncing around your headset.
Welcome. Hi. You can sit yourself wherever you're comfortable. You can either go.
Do you feel more comfortable over here, actually?
That's fine. So the floor is yours.
Oh, great.
Do you want to get yourself settled?
Yeah.
Yeah. Should we pick up the performance report quickly while we're waiting, rather than silence? So Eileen.
Thank you. So performance. So you've got a lot of performance in your pack, and the first thing to say is that what we did the Delivery Performance Committee, the board has had a couple of runs at meetings now. I think we started with not a lot of information, and now we have to. And so this is the last time you will see it in this current form because we will streamline it and make sure that the detail is available in a different way and that it's readable, because trying to navigate it, even as the person presenting it at the DMP, was quite a challenge. We were, having said that, I think it's an improvement on where we started, but it's not easy to navigate, but it is a work in progress. So all the sort of usual highlights, lowlights, as you would expect from a performance report. I mean, I think we've talked, we've touched on winter, and I think that there are some things that certainly as a board we need to be aware of if we're not already. All of our providers, and I include mental health in that, are under severe pressure at the moment, and that seems to be, doesn't seem to be abating particularly. So we're very aware of that. And as we are doing the winter planning and getting the planning towards completion and then implementation, we do have to acknowledge that we are starting from a position that is perhaps not as favourable as it has been in previous years, albeit it's always difficult. But I think we have some particular challenges around that. So you know, in the pack, there's a lot of narrative and some dashboards around emergency access and pressures, and it paints a picture of great difficulty. But and Yvonne will touch on this around the quality angle. We do need to be really clear that we are carrying a great deal of risk here as sitting around this table, and also people specifically who are on the front line of this. But we do need to be cognizant with any planning that we do that we actually make it better, because I think the sun is out, we're not in winter yet, and I think everybody is quite fearful about what we are already facing and then going forward into a much more difficult picture. So Yvonne is very much plugged into a lot of this work, along with Matt, to see what we can do to help so that things are slightly relieved. Just going through other bits of the report. So cancer, obviously, you'll see again the dashboard. It's busy, you know, back to pre-pandemic levels, and I think the challenges now are the same challenges that we had that we've always had. So 62 days, for example, is always consistently difficult to achieve consistency because of all sorts of reasons. Lower denominators. It only takes a handful of patients to go off to a tertiary centre, and then they might be there longer than usual, and so it's always a challenge. I don't think it's special to us, but I think it's of note. But there are some positives in there. So there are some upticks that we seem to at least be holding the line. Obviously, lots of work is going on around RTT, and there was a particular push at the end of July around 104 weeks to make sure that we didn't have any breaches for capacity issues. One of the things the Delivery and Performance Committee, we are feeling our way through it, but one of the things we're trying to do is make sure that we are also looking at other matrices that we have available to us to check that we are looking, there's nothing that's going to fall through the cracks, so that we are cognizant and aware as a Delivery and Performance Committee of where we need to be focusing some attention. So I've already talked, and Angela has as well, around mental health services being under pressure. And there are some things around things like annual health checks and so forth that we really need to understand the driver of the difficulty, but also how we help fix it. So it's not just something that has appeared historically as a difficult area, and it's a wicked issue that we never get underneath. So we are trying to be sort of broader in our approach, and also just within your pack is lots of information around the autumn vaccination programme, which starts on first week of September for cohorts 1 to 9. So, and included in with that, of course, is health and social care staff and anybody over the age of 5 that's considered to be at risk. So I guess we'll touch on winter and winter planning, perhaps a different part of this, or how would you like to play it? I think Yvonne was going to touch on it, but just to say there is a lot of work going on whilst we try and refine the pack and the data so that it actually tells a story as opposed to buries us in information and data. So it's a work in progress.
So we will pick up winter and equality then. Simon.
Thanks, and I recognise obviously this is work in progress, new report, all of that, so taken as work in progress. I think it would be helpful for us to start, as we think about refining the data. 2 points occur just as I read this chart, so that I'll read this narrative. The first is one of the key underlying sentinel indicators is the number of people in hospital who don't otherwise need to be. And if we don't get, it's as I know Angela and I have talked about, it's an issue for mental health, it's very much an issue for acute. So I think there's things that we need to pick out which we might refer to as sentinel indicators of performance, because if we don't get a handle on and make progress on discharge across a range of different domains, then a lot of the progress that we have made will be put at risk as we go into the months ahead. the related point is you could be forgiven if you read this for thinking that we don't have a problem with ambulance handovers, and that is obviously not the case. We have a differentiated problem of handovers. So I think as we go into the beyond the sentinel indicators, I think we need to think about where in the county are there specific problems, because it would be remiss of me not to flag, obviously, with the very small size of the NGH A&E, coupled with some of the problems I've just referred to around discharge, coupled with the fact that we have got less urgent treatment type facilities in that place. We've got a huge compression of activity, and I'm sure that's the case in other sectors as well, but I just think we need to think about differentiating the messaging and getting a little bit more nuanced, would be my kind of 2 points. And think, as I said, very carefully about the sentinel indicators, on which I would strongly encourage us to think through reason to reside or associated indicators, which will topple us all over if we're not careful.
Thank you. Janet?
Just to give you some assurance, there was a significant discussion around ambulance handovers at the Delivery and Performance Committee, as well as delayed discharges. Perhaps not articulated in the points that Eileen made, but we did go into it in some depth.
And if it would be helpful, I'm sure there's some of us who'd be willing to kind of help refine the narrative that we present here, because I think it should be our narrative across the system, if we're in this new kind of way of working with one another.
Thank you. Angela?
It's just recognising so we can develop it. I'm just trying to work where we would see our people metrics, and where we see how we as a board understand what's happening with our people, if we look at our people board, staff sicknesses, those sorts of indicators. But that's something we're thinking about it in an integrated report, or it'll appear somewhere else to support on. We talked a lot about that today, actually, about workforce and how, where, what, why. It's abstract, and obviously we're all indicating it's one of our highest risk areas for everything we're trying to do. So we just say we take it away and give it some thought about how we're thinking with Chris and other colleagues about giving that full picture without duplication.
So I think building really on a few comments that people have made, I think I would really value seeing the key things that we really need to add, we need to, as a board, focus on and add value to. That's not to say there aren't a whole load of other indicators behind this, but we really need to see the wood for the trees. So I'd like a sort of smaller dashboard that we focus on, but with background data that we can all look at and raise concerns about. I'd also like to understand what the committee's doing, what assurance it's got from the discussions that it's had, and what issues it needs to bring to our attention so that we as a board can agree things that we need to take forward. So for me, that it's really important that the committee shows us what it's doing and that should, by the way, we mustn't forget our aspiration to involve people from our organisations who already scrutinise these things in some cases and may be able to add value. So I do think that way we kind of build up a better picture here. And what I wouldn't want us to do is repeat conversations that have already happened at committee. If, there's assurance and action being taken, we just need to know that. The job of the board is to address the issues and address barriers and make sure that we're taking those things forward that the committee hasn't been able to resolve.
Okay. Yeah, thank you. I would repeat comments that others have made. And say the report being iterated going forward is helpful. It's a little bit of it, clearly in terms of the level of detail within it, but now we've got so much in there. I think this does play, as you say, Christian, to role of this board, role of committees, how some of that relates to collaboratives and providers in terms of performance oversight. And like all ICBs across the country, we've got a journey to go in terms of finding our way through some of that. I think some of our development session space and informal mode needs to apply some of our thoughts to that. I've also arranged with Naomi to meet in September with the chairs of each of our committees and their executive leads in terms of doing an initial reflection on the first few months that they have been running and thoughts on how we can move those forwards.
I think for me, the quality report today actually is quite an interesting one because it's a first step and move towards trying to just elevate out from all of the detail that the committee sees a relatively small number of things that that particular committee and the chair and the executive for that forum feel need to hear. The other thing that just reference on silence that we'll need to continue to work through is how that set of local arrangements connect with our regulatory frameworks in terms of NHS England's memorandums of understandings with all of the 42 ICBs and the expectations there around performance and oversight. I think for me it's about how we make that work locally in the spirit of what we're trying to do here, which is a more collaborative distributed approach. But let's just say I think there'll be some tensions to work through in terms of some of the elements of that as we go forward. Thank you.
Thank you. Finally, Janet.
Yeah, so in the committees that I'm chairing, there's definitely queries about some of the enablers and where they sit at the moment in the committee structure. So as we've just mentioned about the people committee, where all of that work gets reported and actually whether it's a thread that goes through many. I think there are things in terms of communication from, you know, a bit like reporting back to this board about the top 3 things as the chair of the committee that, you know, I'm reporting back to the board that I think we can, which we'll be able to bring up when we do the feedback with yourselves and Naomi. But there's also something about where the papers go. So, you know, it's never an excuse not to know what's there and that you've missed something. But there may be simpler ways of being able to house the information that we've got so people can dip in and read that. And that could be through an administrative system that we might want to introduce within the ICB for that purpose. So there are lots of things to think about when it comes to evaluation.
Okay, a clear request there for a board administration system. I think that can go noted.
Namely, I discussed earlier.
And supported. Marvellous. Thank you, Eileen. So, David, thank you for your patience.
Sorry?
Over to you on the ICANN case for change.
Great. Well, first of all, thank you for having me, and hello to those I don't know. I know most people, so thank you for being Janet as mum. I don't think we've met before. I'm the Managing Director and Deputy Chief Executive at NHFT and one of the exec sponsors for the ICANN programme. So I'm here for Anna Earnshaw, who's on leave. She's the exec SRO for the programme. So what I propose to do is just briefly go through some of the materials that are in your pack. The cover sheet sets out what we're asking for here, which is progression to a further gateway in the ICANN collaborative case for change development. It sets out a rationale for how we've got to this point, which is in the cover sheet pack. And then it talks us through some of the governance processes that we're aiming to put in place to help us put some shape and structure around the next phase of the work. So can I just check what people had in front of them? Have they got the storyboard slide deck?
We have.
Okay. So if I just take maybe 10 minutes to go through that, Andrew, and then kind of break for conversation. So, I mean, the purpose of what we're trying to do here, as I said, is get to a point where you feel confident that we as a partnership are able to move beyond where we are now to a point of being able to ask ourselves how we could begin to earn our autonomy and seek delegation to go further with our work through a collaboration. That'll involve thinking about delegated budgets and different contract forms to help us get the outcomes that we seek. So page 3 gives you an overview of kind of where we've been and why we're at this point. And most people in the room are familiar with the antecedents for ICANN, but it's driven predominantly around ageing population growth. You'll note the census from this year, well, the most recent census has a 6% increase in our older adult population, which isn't actually factored into our numbers here, but illustrates kind of the growing complexity of the issue. We've got an issue in terms of managing our demand to ensure people can stay well at home and avoid unnecessary admissions. And the idiom I use when I think about this is the Nigel Crisp book title of Health Being Made at Home, Hospitals Are for Repair. And I think that kind of sums up very neatly what we're kind of trying to do with ICANN, which is really develop models of care and health at a community level so that when people need hospital, they need it actually when they need it most. We also are driven by what our clinicians and our patients say, and this is very much if Mark Major was here, or some of our primary care clinicians, they are central to how we're building this model. We've got a triumvirate leadership model in place with a clinician, a manager and a patient driving the programme of change across the collaborative. So that's quite important to our mission and our values. So on slide 4, we talked through some of the kind of stage. We've nicked this with pride from the mental health collaborative, but we're kind of focusing on 4 key areas in terms of being outcome focused. So getting the right set of outcomes to drive improvements in the system, be that length of stay, reducing demand at the front door, helping people stay at home in a more independent way, and developing kind of individualised care plans which are built around kind of the needs of the individual and their preferences. The person-centeredness element of it is very much now beginning to fall into place around place and the emerging framework for the 2 local authorities. We've talked before about neighbourhoods being a framework that bring the community sector together to deliver outcomes, and that's very much been embraced by both North and West, who are developing local area partnerships, which will fit really well into this person-centred responsive model that we outline here. And then in terms of integration, we really are looking for a partnership that could take on the full responsibility of managing the pathways for this particular population. There is a debate to be had about whether we go beyond this population group, and I'm sure we'll come to that in the plenary discussion. So on slide 5, I've got an outline of what we're proposing and why. So it's a 5-year programme. We've had some support in to December 2022 to help us with some of the analytics underneath this from Europe. That's currently funded, as is the programme resource. We now need to kind of get on with bedding in the programme across the partner organisations. That means writing down what we intend to do, writing down who's involved, and writing down how we intend to be measured and monitored against the outcomes that we seek and agree with you as a collaborative partnership. The focus, as I said, is the frail and over 65s. There is a debate, I think, that we'll come on to as part of the winter discussion about how we wrap up some of our unplanned work more generally in this, because that does add complexity to it. So, for example, the intermediate care team in NHFT is not an age-specific service, as are a number of the services they're not all age-specific. So there is complications with how we manage and begin to construct the collaborative around this. We're proposing that the BCF will be our initial start for 10 in terms of how we'd approach the contracting framework. And that's partially because the BCF is there. We've used it. It's an existing Section 75 agreement that partners have well-practiced kind of input to. So we think that gives us a good solid basis to begin to look at how we use that resource and then build governance around it, which is fit for the future. I'll pause just briefly on the gateways, which are on slide 6. So you can see that we feel we're up to point 3 in the roadmap. Some people might differ, but that's certainly our perspective, that we feel we've set out where we're coming from, articulated a vision about where we want to go. We've got a map about what we need to do next in terms of how we're going to get there. And now we want to move on to the next stage of developing our governance and the accountability to get to a point where we have something that bakes this in as an agreement, a collaborative framework for the system that will withstand the future tests, and those will be many, I'm sure. So I'm not going to go through slides 8 onwards, but I will do slide 7 and then begin to close down. Slide 7 begins to give you a sense of what we're suggesting could be in scope in the early stages of the programme. Some of these are already working very much hand in glove, but it tries to illustrate a framework around shared points of access, a comprehensive approach to integrated multidisciplinary team support, and a wide-ranging community health and care provision, which we've been doing some excellent work in Ageing Well, which has been part of our HSJ success. We then have an integrated discharge intermediate care service, which is some of the paperwork that you're going to look at after this in private session around how we look at our community bed provision and think about using those pathways differently. And then getting into thinking about winter and surge planning, which Arlene talked about, being something that we're going to discuss under the quality section. So that, I think, gives us a full community-facing framework for thinking about our communities and how to manage their needs. And there are a set of services within there that we would want to align to help us achieve our outcomes. And by bringing them into closer alignment, it allows us to plan in a much more clear, vivid way for a better outcome. So what would be different? This is on slide 11. There's a section for patients in terms of people feeling that they're linked into their wider support networks. And I know Stuart and Rob and colleagues and others from local authorities are trying to achieve this at a place level. So how will people feel like their care is personalised, and how will they feel like it's local? And that's very much what we're trying to achieve for patients, because that's what they've told us they want. For GPs and indeed for the wider primary care community, I think they'll find that they have better coordinated access for their patients. So it is easier to reach out and have a single point of contact to help them navigate the system of support for patients. And also it'll bring those support networks into much closer alignment around social prescribing and some of the wider community aspects of care within the voluntary sector. For the partnership, for the ICS, we aim to get to a point where some of the red areas that talked about in the previous performance report, that we can really begin to tackle some of those. They're outlined in the pack, length of stay, emergency admissions, and so on and so forth. So we think we're a critical part of that solution to some of those performance challenges. And for staff, we think they'll feel like they work in an organisation that is driven for best outcomes for our patients, that we're actually part of one public sector working in harmony to try and get better outcomes for patients. And we've talked before in governors' meetings, I think, Alan, about the awesome social value that is locked into an integrated system like this. So how do we untap that for our staff by bringing them together to work collectively to find solutions that matter to them, to their patients? And we've seen that work brilliantly in some of the work we've done in A&E with Trust Plus on wards, with primary care, supporting discharge. So there is a real untapped opportunity there to bring social care, hospital care and primary and community care together. 12, 13, 14 and 15, we can take you through some of the kind of tranches that we're proposing. We're going to propose 3 phases, similar to how mental health have approached their work. So we propose to look at tranche 1, bringing us up to the end of April with a go live position, and then begin to move towards tranche 2 and 3 over the next kind of 2 to 3 years. What we would be obsessed with between now and the end of April, of course, is getting the correct governance framework in place, which is the Gateway 4 that we're asking for your endorsement to proceed through. There's a slide on budgets. I suspect we would come back to that in the governance discussion when we get to Gateway 4 and begin to talk about contracting and agreements and so on. So I'm not going to kind of labour or go into too much detail on that, but give you a sense of the timescales on slide 15 in terms of how we're moving forward with different staging posts to try to get to a point where we function in a reasonably autonomous way within a fully transparent and accountable way. Thanks.
Thank you, David. So we're looking to prove that we've moved through Gateway 3 and can move on to Gateway 4, recognising the conversations that we've had to take back around governance. Sarah's been twitching since you mentioned BCF, so I'm going to hand it straight over to Sarah.
I think it's really, thank you, to reiterate the point about what we are approving and therefore the status. So there is quite a lot in this deck about Gateway 4 and Gateway 5, potential contracting, delegating models and budgets. I think probably just to reiterate to the room that is indicative currently. It isn't necessarily even a proposal. I think it's direction of travel. It's sensible for them in terms of how we might do that, but I think there are various other options that through the course of working through Gateway 4 and 5 we'll need to look at the whole in terms of how we might do some of that. So I just wanted probably to comment rather than question in terms of the status of what's outlined in here in terms of the potential content of Gateway 4 and 5, because I think there is still a way to go in terms of both the agreement and the structure of some of that, and conversations around with various of the partners around this table will be required for us to run that. So just in terms of how we move through Gateway 4 and 5, I think is the next step for the collaborative and to kind of work through. And therefore, the indicative direction of travel nature of what's in here rather than necessarily firm proposal, I think is just important for us to know.
Rob. Yeah, so just I suppose to build on what Sarah said, so next week, Thanks Executive are considering this proposal, and I think I've said before around this table that some of my councillors have concern around democratic deficit around this table, and I just mean that because it make reference to the BCF, obviously that's money that comes into local authority but also goes out into the places, and so they're obviously asking questions about, hold on a minute, where do members get cited on this? So what they're looking to approve, and it's just a recommendation, is to absolutely endorse the direction of travel. But what is likely to come out is a communication written response from our executive member for health to the ICB chair and chief exec and the ICANN senior responsible officer, just to sort of say about member oversight of some of these funds. And this is back to the governance point, so I think it plays into the next iteration around how that governance will work, and I think seeking a conversation really around North members and making sure where all this sits. And I think it's all easily sorted through a conversation and a response to it, but just wanted to be clear that's what the Northants exec are likely to approve next week as they're part of this.
Toby. Yeah, thank you. So firstly, welcome what's here, and I think the ask specifically today, as Sarah's clarified, kind of 1 to 3 stages of this is absolutely something that has my full support. There's been a lot of work across a whole host of different partners around this table, operational, getting to this point. So very much supportive of that kind of operational piece. I think, as building both Sarah and Rob's comments, that the critical next steps in this feel to me like the scope question in terms of slide 7 in the deck, in terms of tranche 1, what's in scope, what's out of scope. So we're really clear and specific. There's some very, very critical services and functions within there, and quite a broad mix of them. And I think working that through feels like it's a key part of the next step. But alongside that, the question around how that then gets taken forwards in terms of core budget resource, contracting arrangements. Are we describing a single county-wide thing here? Are we describing 2 place-based levels? I can imagine, Rob, from a democratic deficit perspective, there's some appeal potentially actually in connecting this very much into a 2 health and wellbeing board and place arrangements, because that automatically starts to build in some of that connection, potentially takes into kind of a 2 rather than 1 approach. We don't need to resolve that today. That's for the next phase of work. We just wanted to note that I think the good work to this point was some really crunchy stuff now to work through over the next period to try and get alignment, particularly given the ambition in here, which I absolutely support and back, which is wanting to get somewhere very different for next April and for next financial year. But given the scale of some of the things we're describing, I think that's quite a big ask, and therefore something that we're going to need to understand how different partners around this table play into different bits of that discussion to move this forward in a way that it can land safely and crucially in something that reinforces what we're trying to lead through, particularly the place-based integration that's at the heart of all of this. Thank you.
Thank you. Simon. Thanks. So entirely supportive of the direction of travel. I think as we come around it, and to build on Toby's point about crunchy discussions, I was very struck by the slides that had budgets for a collaborative delivery model in there. And one of the big problems we face at the moment, and this I think will be a question of our aspiration but also clarity around that, is that as we sit here yesterday, there were 51 people in Northampton Hospital who are waiting for a P1 package of care. So that's nearly 2 wards worth of patients. And on average at the moment they wait 10 days before they get that package of care. That's not a new problem. It's been something that's been with us for quite a few years in Northamptonshire. So the idea that we're approving here is that by bringing services together in a more integrated way and breaking down organisational boundaries, we can do better on solving some of those problems. I think that's at the heart of the P2 idea that we will discuss later. It's the heart of this idea. So while I completely support it, we've got to be clear that this will solve that problem. Because carrying on as we are, with the P1 issue that we've got, affects both parts of the county in differential ways. The main is particularly bad in Northampton, is also not tenable. So I just want to draw a link between the operational reality and the ability of this programme, this proposal, to help us solve that problem.
And then finally, Naomi.
Thanks very much. I mean, obviously, I endorse the direction of travel. I think this is a brilliant piece of work, and it's one of the areas where it's so obvious how important integration and working together is, and it's where all this started. The only comment I would make, and I've seen these papers a lot, so I've never made it before, and I apologize, but it's just, yet again, I don't see inequalities in health woven through this material in terms of issues like race and socioeconomic status and gender, which I am sure when the detailed work happens, you will find that there is difference, that there will be differences in access to services and the way people are treated. And I just like to see those issues carried through in our operational papers, not just in a separate paper. But it's a very good piece of work, and I thank you.
Thank you. Anything you want to add, David?
No, just welcome all the comments and the support. I mean, I think it is next phase is crunchy, to use a fairly apt word, I think. But I think the strength of the partnership that's got us this far, I think will get us beyond that. I have every confidence in that. I think Naomi's points are very well made about health inequalities, just that running narrative through this. I mean, it's assumed in here in terms of place-based working and the model for neighbourhoods, but I think we can be a lot more explicit in terms of what that actually means at a very local level for people.
Brilliant. So we're looking to approve moving through level 3, it's gateway to stage 4, recognising the complexities and the sensitivities and considerations within government's work and budget work that needs to be done. Thank you. Thanks a lot. Brilliant. Okay, is everyone okay? We've got one more item, so rather than taking a break, we'd like to continue and making sure we finish by half. Okay. Okay, so we move on to Yvonne and a new style report, which I'm sure you want some feedback on as well.
Yes, thank you, Chair. It is a short report this month, as you've already alluded to, but just to say that this is work in progress. We've got a part of the system quality group where we're collaboratively developing the system quality report, because I think, alluding to previous comments, it is a report that we all need to own and we all need to sign up to. And also, I think it needs to spread more across the breadth of services and across our population and be more outcome focused. So we're hoping that it's more inclusive of mental health, learning disability and autism, primary care and more community focused. So this is a work in progress. And then what we're hoping to do is then bring an assure, advise and alert report from the system quality group, which really highlight the key risks and the key priorities that board are aware of and can focus on. So that's the direction of travel. Having said that, the key areas that I just want to pull out of this month's report are the continued sort of concerns around Corby Urgent Care Centre, the Risk Quality Improvement Board in place. Matt and I have met with the senior executive team. We've had some assurance that there's no new concerns from CQC and that progress is going forward. Maternity services at NGH was also discussed at the system quality group, and we acknowledge the ongoing improvement work around staffing, leadership and culture, which has also been supported by the LM&S, and I'm keen that in future LM&S reports go through the system quality group as well, so that we can flag risks in that really key focused area to board as well. St Andrews and their previous CQC inspection is also highlighted and mentioned in the report is impact, but also just to note the work of the East Midlands Alliance and quality improvement work with the support of the CNO from NHFT as the improvement director and also NHFT as the buddy trust. We are still waiting further reports from CQC in that related to that service. In terms of inequalities, just to note, we're currently not compliant with our initial health checks or our review health checks for our looked after children. We're obviously a really vulnerable group. So there are some process issues in terms of when the alerts are received, and then there's also some further process issues of how they're diarised and how the health reviews are actually appointed. So we've got some process mapping and some improvements plans being developed collaboratively around our looked after children. And as previous, and their health reviews, and as we've already previously alluded to, it'd be really remiss of me not to mention from a quality and safety perspective our current issues in terms of our urgent and emergency pathways within the system, both in terms of ambulance delays and outside ED departments, and then the potential delays that can have for our rest of our population, long waits in ED that can lead to obviously poor quality in starting treatment in a timely way, and also the high numbers of patients who don't meet the criteria to reside within hospital, and the impact that then has within flow within our system. So I think there's some really key quality risks that just to highlight the board. In terms of winter planning, I think it's really essential that we try to all focus on getting our urgent and emergency care system as good as it can be before winter. So moving into the sort of winter planning, we're in a system that's functioning effectively in that way. Eileen, I don't know if you want to say anything else about winter planning.
Just in terms of where we're at with winter planning, so the crews across the system have been meeting for quite some time, actually, along with the UEC team here, and I've been involved more recently. But so I think what we've got at the moment, we may end up with is a set of schemes that we will try and bring in time for winter, so that we alleviate some of the pressure and also remain as safe as we can be going through the winter period. I think there are some challenges within that. One is affordability, the other is doability and the workforce. But some of the suggestions are sort of tried and tested and perennial. They have a perennial outing in terms of getting things back in on the patch. But I think that obviously that in the private passport we'll be looking at perhaps trying to do things differently compared to what we normally do, which is just putting some schemes in and hoping that they work and are sufficient. The difference, I think, this year, in fact, prior to this meeting, I've just come off another regional call around the scrutiny that we will be under as an ICB, and they're very clear about this. The ICB will be under the scrutiny of money coming down, which it will, what we spending it on what we said we'd spend it on, and actually that it will have the desired effect. So I think we can expect, and in fact I've just been told that we're going from the national team, we'll get trajectories for our area around our improvements. So that'll be interesting to wait and see what that looks like. Hopefully that will be a helpful thing as opposed to feeding the beast, but it will be what it will be. But most importantly, we have to have very honest and open discussions about our ability to do some of these things so that we can actually get going. And that's also the other message from the regional team today: get going, so that we are, although we sit here in August now, that we are ready for October, November, December, January. No surprises; those are predicted to be our peak times in terms of demand, and also our peak times in terms of difficulty. So there is a lot of work, and it is changing by the hour, not just by the day. And there's a whole heap of people sitting next door from all of our organisations trying to pull this together to see what we can do, and if we can't do that, what else could we do? So that's sort of where we're up to with winter planning, not being too cryptic about it, but there's a lot of work going on.
Thank you. The only piece I wanted to add into that from a winter and a quality and risk and harm perspective is, I think someone else referenced it earlier in the conversation. I've asked Matt and Yvonne to work together jointly with clinical colleagues and care professional groups across the system to work out for the period we're going into, how do we get a more meaningful and active conversation about balancing risk across different settings of care within the system as we go through what will inevitably, notwithstanding the schemes and other things we do, I think it's a racing a really challenging winter period. And how do we make sure that we've got that clinical and care perspective on risk and harm in different settings in a more visible way that can be kind of balanced and more actively managed. I know that's something we've discussed in previous years in the system. We're frank and honest with ourselves, we struggle at times to be able to really do that in a meaningful way. I think it's an opportunity with the ICB bringing us together, and particularly with your two leadership roles within your respective communities to help with that.
To add to that as well, the whole of the Nexus and Quality Group has been given over 2 years, so we can identify our success.
Chair, if I may, just also talking about that, Julian, we have some useful learning from the system-wide major incident at the beginning of this calendar year, where we jointly with clinically and operational leadership came up with a stratification framework for how to prioritise services that must be preserved, etc., etc. And I think we could hopefully replicate a similar approach to system prioritisation for Winter.
Angela.
Just say, I really welcome the emergence of that summary and that alert and that way. I really do like that approach, recognising that we're still working on how we feed all of that information through. It's just a wider point, I think, more generally for the board in terms of urgent emergency care pathways. And we often talk about that, and we often talk about that in relation, of course, to what we've just described, the acute sector, and a clearly important focus that we've got there. Just want us to be careful about the fact that if you're somebody with a mental health condition with SMI in the community, you need urgent emergency care as well. Now, that may be for mental health services, but we need to be clear when we're talking flexibly, what are we describing? Because we don't want to exclude part of our population who need access to urgent emergency care. And again, similarly, as I've said earlier, the occupancy levels in those services are pretty high, at 100%. So it's just it's totally understandable how we do it. It's how it's framed nationally as well, but it's important for us to consider the wider access points that I think would help us to understand the needs of all the population.
Noted. Any further comments or questions?
Rob? Just one from me on the looked after children, and maybe I'm just being a bit dim. Makes reference to NGH. Is there no issue in catering?
It's done by NHFT.
Whereas it makes reference to NGH as well.
Yes, it's done by both.
Both, but catering doesn't. So okay, I just thought I'd ask.
Yeah.
There we go. Totally difficult question.
And just a simple question for me in terms of if we have meetings over the next few days that come up with good, strong plans that fall outside of delegated authority levels for getting things moving, what's the plan to get things going quickly? Because winter is a set time, it is going to happen.
So some of the plans that are already underway, because obviously there's a meeting time around starting. So albeit that we haven't yet got to a point where we've signed off exactly what we're going forward with, there are some things within it that we know that we will have to do. So therefore they have put you delays. So, but it's always a race against time at this time of year. But for example, Jean in NHFT, that recruitment is underway. So we're trying to be as fast as possible. Hence why whatever decisions we land on, we need to land them now, because otherwise if we take too much longer, we will be into winter, and then we'll be forced into doing what we often do in all sorts of systems, whereby we end up having to staff ways of working with very expensive premium rate agency staff, which we're trying to avoid.
Thank you, Debbie. Specifically for your question about where and how do you make decisions quickly, a number of us as executives around this table are meeting following this session today in order to make some short-term decisions that we need to that have got time-critical decisions that if we don't get them now, we're going to struggle to lead time. So that also goes to say that some of our committees or this board might find that we report things in at different points over the coming weeks and months where it is most timely to be able to do that, but making sure that we don't let that be the piece that slows down getting the stuff that we need to do.
Okay, thank you. So in terms of closing comments, I think winter will define us in terms of Simon made a point at the very beginning of the meeting, and I think it's crystal clear that how we respond is going to be essential both internally and externally. I think it's a real opportunity to actually show that our staff that we can do things differently. So any help that we can give to those ongoing conversations, please ask. The second point was around the nuanced messaging and really trying to bring out who ICB is responsible for, accountable for, where it should be collaborating, and where responsibilities sit for other things outside of the ICB. I think it's a bit of a permission for the exec team to actually be making some of those calls, working in collaboration with the committees, but also with colleagues from the partnership, that actually we as a board want to see some decisions being made in terms of these are the top 5 things we need to be talking about in this area, and bring those to us rather than sort of the weighty detail which we can access through this wonderful new system that we're going to get. And I think just pick up on a question that Gemma asked, it's that so what question. So what's important, what's needed from the board, which I think over the coming sort of couple of sessions we should be asking more and more of ourselves. And finally, thank you for your patience. And you've got 10 minutes back in your diary, so we have finished with 10 minutes to spare. So I suggest we take a 10-minute break, reconvene at 22 for the private meeting. Thank you all very much.